The date is June 22nd, 1973. We're in Toronto. This is Gerald Rayner, and I have the distinct privilege of interviewing Dr. Bill Bigelow at his home. We've had a pleasant dinner to sort of rehash the content of what he might say, but what he might say really is quite informal and is to bring to us some of the historical memories that he has that led him to play the vital role that he did play in the beginning of cardiac surgery. I'm going to ask Dr. Bigelow to start off by going back to the very beginning of in recounting the things that prompted him to get into the experimentation of the effects of hypothermia on the body and especially the heart, and to take it from there. Dr. Bigelow.
Dr. Rayner, I suppose most people are interested in what prompts someone to delve into an area of research or study that may be new, and I don't think it was anything particularly dramatic. It just seemed to evolve, and I would think that my interest in cold probably started as a resident in about 1940. Before joining the Army, I remember presenting a case of frostbite to Dr. W. Galley, who was chairman of the Department of Surgery at that time, and a very wonderful person, very stimulating person. And I had read the literature prior to my case presentation on rounds and found that it was very little known in the English-speaking language. And I brought this out on rounds. I was very disturbed that we as Canadians should know so little about frostbite. He called me over at coffee that morning and said, "Why don't you pursue this?" And which I did. It really didn't require much, but a word from him was a stimulus. I reviewed the foreign literature and also found a marked limitation in the knowledge of the pathogenesis and treatment of frostbite. Dr. Galley further, when he realized that he'd kindled some interest in me, asked me to interview a man by the name of Krayberg, who was in a Norwegian establishment here in Toronto during the war. And he had done some of the original work on microcirculation and cold. And I became acquainted with this. Actually, this eventually led into our team's interest in the microcirculation and the work of Melvin Knisley and others. It tied in with hypothermia, actually, eventually. But with this knowledge of cold and the fact that it reduces metabolism, I went off overseas. And whiling away the hours in Britain before the second front opened in Northwest Europe, I made some connection with a British refrigeration engineer, and we designed a cabinet which was supposed to be mobile and could presumably be used to cool the lower extremity or upper extremity of a wounded soldier and keep the tissues viable until he could have a revascularization procedure. And this, interestingly enough, was accepted by the War Office, and they gave the contract to a British firm. I think were originally designed to make war tanks or something, and it was completed on VJ Day. I think it weighed something like the better part of a ton, I would think. It certainly didn't look very, very mobile to me. When I came back to Toronto, I suppose still with metabolism and hypothermia on one's mind once in a while, and was advised by Dr. Galley that I could work into a career in vascular surgery if that interested me, and having agreed to this, he sent me down to work with Alfred Blaylock and Hopkins. Instead of working with the great surgeon, I was sent to work in Richard Bing's lab, which was initially rather a come down, someone interested in doing surgery, but of course, as it turned out, Bing at that time was doing the first cardiac catheterizations on humans, and it was a fascinating 6 months I spent with him, Van Dam, who's later become very famous in anesthesia. And I watched the Blue Baby operations, and we talked heart surgery, and the frustrations of not being able to fix the Blue Baby and correct the ventricular septal defect. Actually, all we were doing was temporary operation. And during this 6 months that I spent, I heard about Gibbon with a heart-lung pump. And this may sound very dramatic, but in my little old rooming house near the hospital, I woke up one night, and the whole picture of hypothermia was very clear to me. You cool the body, and you interrupt the circulation, and you get inside the heart. I spoke to several people around the hospital about this, and they thought it sounded rather outlandish, but I could hardly wait to get back to Toronto, having finished my fellowship and come back on the staff. And we set to work on hypothermia then, and this was the beginning of our studies on hypothermia. And that is rather prosaic in some sense, but I guess I give you that background simply because I'm impressed with the fact that it's probably unusual to have any sort of an idea that is in any sense new, that doesn't land on some prepared soil. I mean, I was thinking in terms of cold.
Now, didn't your work then lead you to present a paper, and what was it, in the late 40s at the American Surgical, that got other people to thinking, that sort of caused some other seeds to land on prepared soil?
Yes, I think that's a fair assessment from what I've learned from speaking to others subsequently. We studied the principle of hypothermia, and I suppose it's interesting to realize that when I came back and looked up the literature, I was a bit dismayed to find that the current experimental work up to that time indicated that cooling an intact animal actually increased the oxygen consumption. I couldn't find an article that supported my theory, although in fact the oxygen consumption did fall after the animal became stuporous and anesthetic from cold. And so we worked with this and found that if we totally controlled all the shivering and rigor in the muscle, that we could in fact get a fairly straight line relationship. And I suppose that was a contribution. It was encouraging to find that we could reduce the temperature, but we were frustrated to find that in all the experimental animals that we worked on, there was a ventricular fibrillation or cardiac standstill occurred in the adult animal around 20 degrees centigrade, which didn't give us as much time inside the heart as we had hoped. We'd hoped to get lower temperatures. But anyway, we were prompted to report, as you mentioned, our work as it stood at that time, cooling dogs to 20 degrees and opening the heart for 20 minutes. And we took a moving picture of the inside of the right atrium and the right ventricle, which I guess was probably unique and was thrilling to see. Matter of fact, we've lost that movie. I don't know where it is now. But several people, as you've mentioned, have told me that this seemed to stimulate their thinking, and obviously it had fallen on rich soil, Lilla High and Henry Swan, John Lewis. So that was thrilling to think that we'd stimulated thought elsewhere.
What can you think of, what do you recall was your first application of hypothermia to the clinical person? The first time that you opened the heart of a human being to do something, and what were your thoughts and approach at the time?
Well, I guess some of the drama was removed because we couldn't come by a case of atrial septal defect, which was the obvious thing to start on. for a while, and so we took some very poor risk patients that ordinarily we would not operate on, and we cooled them and did mitral split on a patient in chronic failure, living in an orthopneic condition. And actually, I'm sure we seemed to get by with surgery in those that would perhaps have been a higher risk otherwise. So that when we came to cool a patient for open heart surgery, we'd already been through the initial stages. I remember the first time we cooled a patient, I think there must have been 28 people in the operating room, and there's a great big fan blowing air over two large blocks of ice to keep the operating room cool. And it was great excitement. But that just evolved into doing atrial septal defects. And of course, John Lewis, to him goes the credit of doing the first open heart procedure. And we followed shortly afterwards, as everyone else did. He broke the ice, and he gave us full credit for having developed the concept, and gave us credit for devising, or at least recommending, the technique of vena cava occlusion.
But in spite of the fact that you weren't the first to do the clinical application of your concept clinically, it still must have been a tremendous thrill when you did your first atrial septal defect.
Oh, I think so. There were so many things going on, and we were in the microcirculation at the time, and we were developing the pacemaker at that same time, that whether we got credit for doing the first human case didn't seem to make much difference. It seemed to be so many more things on the horizon, and life was so full of a number of wonderful things that...
At the time you did your first clinical case, how much time did you judge that you had to do whatever you had to do inside the heart to close the defect?
I think we allowed about 7 minutes. Actually, the time we assessed and the safe level of cooling that we assessed didn't change very much over the years.
7 minutes.
Mm-hmm. And we thought the 28, 29 degrees was safe, and that never changed over the years.
Would you commonly re-occlude for a few moments, restore circulation, then go back for a final act?
Dr. Rayner, we did everything in those days. We re-occluded, we kept it clamped off for too long. Oh, goodness.
What is the most times of occlusion and rest and go back that you can recall?
Oh, I don't recall, really. I suppose maybe 2 or 3 times. I can't think of any excessive number of reclampings. I'll never forget encountering a myxoma in the atrium a matter of a month or so after Crawford had reported the first removal. I bumped into it doing a mitral. So I backed out, and I thought we will cool him in 4 or 5 days and do it properly and do it under open heart technique. And he died the next day because his tumor went down and occluded the valve. And interestingly enough, about 3 months later, doing a routine mitral, I encountered another myxoma, and I thought, well, we can't leave this fellow. So we got some cold saline in and poured cold saline into his open chest. It just seemed to be hours until he was cooled down to 30 degrees. I think the water was about 2 inches deep in the operating room. But we cooled him down. We interrupted the circulation, took the myxoma out, and the fellow did fine. It was the second myxoma ever to be removed, and it was the first one under hypothermia.
Fantastic.
I mean, on the reported in an article, it sounds neat and tidy, but I tell you, it was far from that in the operating room.
Were you in the left chest at the time?
Uh-huh.
And how did you reach across to?
I think we cut across the sternum.
Go across.
Mm-hmm.
Very good. Now I have 2 final things to ask you to sum up. One has to do with your concept of where we stand today in our clinical application to open heart surgery, as you might have envisioned it, 20 years ago. And the second are your elaboration on your thoughts of tenacity that you mentioned to me earlier, which obviously must involve your philosophic concepts of research and pushing ahead in medicine?
So your first question was?
It had to do with your concept of where we stand today, as how you might have envisioned it 20 years ago. Have we gone ahead at the speed you would have guessed, more or less? Did you envision when you first started your open heart surgery clinically that we'd be doing the things we do today?
Well, I did, but I didn't think it would be with the heart-lung pump. I was fearful of all the gadgets and pumping blood through tubes because we'd studied the microcirculation, and I was terribly impressed with the effect of trauma on the blood, even squeezing or cold or any form of trauma. And I thought that at that time my microcirculatory studies discouraged the concept of being able to do what we can do with the bypass. But I really did think we could solve the hypothermia thing, and I visualized being able to clamp off circulation for 2 hours. You can do it with hibernating animals. We soon found that out. And we also found out that a newborn or a premature human is almost identical with a hibernator. He's unstable thermoregulating mechanism. He's a poikilotherm, really. He doesn't sludge as an adult does, and a hibernator doesn't sludge when you cool him. And I thought, we've got all the qualities in an infant or a premature that there is in a hibernator. Therefore, if we can just reverse this endocrine process, we can reestablish what was here already. In other words, we weren't creating something new. So I had great dreams of what we could do with hypothermia, really. But that led us into, well, to finish your question, 20 years, yes, I thought we'd be doing this 20 years hence, but I thought it would be with hypothermia, not with the pump. And in the search for the secret to safe deep hypothermia, we studied hibernation for about 15 years. We never learned the secret. We learned a lot about hibernation and about metabolism. But the hibernators still go down the holes every winter, and their secret is still with them. It's a wonderful secret. They're just incredible animals. It's an amazing quality they have. And they've got a built-in alarm clock. If they cool too far, they automatically arouse. It's amazing. And you talk about tenacity. I think that's a key quality in a researcher, is to be able to stay at a subject long enough to get the most out of it, but not to hang on for so long that you're wasting your time and the time of your staff. I hung on for too long in hibernation. Well, we thought at one time we had the secret, and I think we can all think of examples where we left a subject too soon. I think one of the spin-offs on hypothermia was the Pacemaker, which we reported in 1951 as the first proof that you could stimulate a heart and produce expulsive beats. We had to wait for the transistor battery about 10 or 12 years later. But we never pursued that. It might have been fun to develop that as a transistor.
What prompted you to think of that to begin with? The principle of the pacemaker or external stimulus?
Well, just observing an exposed cold heart and cooling the animal with the heart exposed and observing it. And when it went into standstill, giving a mechanical stimulus, and found that the heart responded with an expulsive beat. And so we thought that the problem in hypothermia and the inability to cool adult animals to low temperatures was perhaps the neurogenic one, that the pacemaker mechanism wasn't working. So we developed the pacemaker to see if we could overcome that. But that historic experiment, when we had the pacemaker set and cooled the animal to the point of standstill, turned on the pacemaker, and it only cooled another 2 degrees, so it's a little disappointing.
Dr. Bigelow, I really can't express our appreciation adequately, I don't think, for simply being able to capture your thoughts in this fashion. I would ask you to cover any final thoughts that you might have just about the broad subject of cardiac surgery or medicine or philosophy of life, or what might turn you on.
Well, Dr. Rayner, you're putting this question to me without any prior consideration as to an answer. I guess I might have two thoughts right off the top of my head. One is that in my association with research, I think the new idea is not as dramatic an episode as we often would like to make it. Historically, I think probably it's created into more of a dramatic episode than it really was. And any work on hypothermia, of course, is built up on work that was done prior by research teams, and we just build on what had already been known and techniques that had been tried, oxygen consumption studies. All these tests were worked out by other people, and we made use of them, just fitted them together a little differently. So it's really not all that dramatic, and we probably shouldn't get as much credit as we do. The other thing, I've used the word "we" in this little discussion we've had, and that's certainly far from a one-man effort. Actually, there's been an interdisciplinary team right from the word go, from 1947. And these men have done most of the work, and they've come up with many of the ideas that we've explored. And you just sort of very often act as a little bit of a catalyst and get far more credit for what you do than you should get. I can't think of any great philosophical thoughts at the moment other than that. I think I think probably we're very research oriented in both the exact sciences and the biological sciences. I think biological scientists try and behave like exact scientists, and they like to make use of numbers and statistical significance. And that's always bothered me, because I realized from the first that if you're dealing with dogs, you've got about a 20% variation from one dog to the other, and the idea of getting a burette so that it's correct to the third decimal place when you're using dogs with that degree of variation immediately impressed me that there's no way in which biological sciences can duplicate the exact science research. And when we start applying the same rules to both types of research, it's the cause for just as much misrepresentation of values as it is a cause of accuracy. I still think that there's a very great place for impressions and intuition in biological research. When you're dealing with such a nebula of variables, you can't sell it to the public without some statistical evidence, some evidence that conforms with the standards set down by the basic scientists.
Well, Dr. Bigelow, again, thank you very much, and it has been delightful, and I'm sure it might be a great deal more inspiring than you might dare realize. Thank you.
Well, thank you. Very interesting to talk to you.